Yeah, so we've done introductions already. Dr. Ayman is one of my consultant colleagues who works in Abu Dhabi, in one of our other level 3 hospitals, which is Tawam. And Dr. Ayman had initially covered the basics of cranial ultrasound, in particular the anatomy. So today, what we're going to do is we're going to have really two aspects. So over the next two sessions, we're going to talk a lot about how we communicate with parents. And then on Sunday, we're going to have a workshop, really, where we'll be showing you images and really putting you on the spot. In that, we'll be showing you and giving you, I'm going to give you real cases with real images, which are completely anonymized. And the intention from our perspective is to get you to kind of counsel in pairs of two, where we do a little bit of role play. But today, what Dr. Amen is going to speak to us about is the initial introduction, the critical role of communication, especially when a baby has neonatal IVH. So, without further ado, I'm going to hand over to you. God bless you. Thank you so much.
Thank you. Hello, everyone. Good evening. So let's start without any more delay. So today we're going to talk about the critical roles of communication in the neonates. Particularly, I'm going to cover the IVH. What's the strategies for engaging parents? So we will cover today a little bit about, I know Dr. Aluk has already covered with his colleagues the IVH, the pathogenesis and importance of communication. I'm going to cover that part particular. And then I will cover the prognosis and the long-term outcome. Because without knowing the prognosis, it's going to be a little bit challenges because you might expect a lot of questions from the parents. So it's better to be prepared. And then we will talk about the parental perspective, navigation to initial information and emotions, and then MDT rules and impact of the culture and the religions. And then at the end, we will do the spikes. We'll cover the spikes mnemonic for counseling. And then maybe that means if we have a time, we can do case scenario, me and Dr. Aluk. So let's start with the introduction to the neonatal IVH. As majority of you guys, and by now should be all of you guys aware that the IVHs, or we should call it germinal matrix IVH, because not all the IVHs cover all bleeds only in IVH. Sometimes you have only bleed in the germinal matrix. So that's why they call it JMH slash IVH. That means germinal matrix hemorrhage slash IVH. It could be this or both. So the primary affecting the premature infant. And as we know, it's carries significant short and long-term complication like developmental delay, cerebral palsy, cognitive impairment, and that's the affect the baby. And in fact, it's affecting also the parent's life. The whole quality of life is going to be affected when their child, lovely child, be affected as well. So it's have a lot of the stressful effect on the acute phase for the parent, and then carry on through the entire life. Originally, the germinal matrix IVH hemorrhage, as we know, is affecting the germinal matrix, which is a highly cellular and vascular structure, as we know. It's the initial site for the neuronal and glial cell proliferation. And that's the continue for all those cells migrate until they're completed by around 24-week gestation. And then gradually the germinal matrix get the regression, and then fully involution should be by around term equivalent age. So for the prognosis, there's some information you should keep it for yourself. And then what you're going to say, or what you're going to tell the parents. So for the professional, if you have a grade 1, so as we know, there is 4 grades of the IVH. By now, should be everybody aware. So grade 1 and grade 2, usually, if there is no just hemorrhage, there is no white matter injury, or no other hemorrhage like cerebellar hemorrhage, the risk of cerebral palsy or mild motor delay, it's very low. But if you have a white matter injury, non-cystic, or punctuate cerebral or cerebellar hemorrhage, then the risk of cerebral palsy, especially ambulant cerebral palsy or mild motor delay, increase. And that's carry mild risk. And then it's higher if involved the limbic, the posterior, particularly the posterior limb of the internal capsule get delayed, the myelination get delayed or absent at the term equivalent age. And or if the lesion to the adjacent, the corticospinal tract get affected, then the risk of the cerebral palsy and motor delays get even higher. Follow-up, 5 years follow-up, delay found that 15 to 20% increase the risk of moderate severe neurodevelopmental impairment, and that's similar to the premature baby without IVH. So in general rules, the preterm baby by itself, it's carry high risk for a neurodevelopmental delay by 15 to 20% if you have it like microbremia, and the smaller organizational age, the higher risk. So it's equivalent to the premature baby. But if you have an advanced IVH, grade 3, without follow-up the post-hemorrhagic dilatation, when just isolated, there is milder risk of the cerebral palsy, majority milder and ambulant. And when they're associated with white matter lesion, particularly, as we said, the posterior limb myelination get delayed or absent, the risk from mild get moderate risk. And follow-up, you will get around 30 to 40% risk of the mild to moderate cognitive impairment. And that's if you have a grade 3 without post-hemorrhagic hydrocephalus. But if you have a grade 3 with progressive post-hemorrhagic dilatation or hydrocephalus, then the risk even further increase. For 5 years outcome, it will be increased from what we said 15 all the way to 35 to 40 risk of moderate to severe neurodevelopmental delay, and 20% risk of the cerebral palsy compared with without hemorrhage. The impairment might to moderate and mainly affect the cognitive impairment. If you have a grade 4, or now we call it periventricular hemorrhagic infarction, then it's going to be significant risk of cerebral palsy, especially if the parietal lobe involved compared with the other lobes. And there's 50% risk of the unilateral spastic type of the cerebral palsy, especially if the posterior limb myelinated get delayed or absent. The risk of cognitive and behavioral visual impairment all get affected. And 5 years follow-up, they found around 35 to 65 moderate to severe risk of neurodevelopmental delay. So that's information, you should keep it for yourself. It's good to know. But when you talk about the parents, you don't want to bring numbers. It's better to keep it unless the parents, they ask you particularly for the percentage. So general, what we say to the parents, for grade 1 and 2, generally associated with lower risk of the short-term serious effect, but long-term usually still being studied, and is equivalent to the baby without IVH. As I said earlier, it's just premature baby itself, it's carry risk of the some neurodevelopmental delay. But if you have a grade 3, then you have to tell them that the risk is higher of the later problem, especially if post-hemorrhagic ventricular dilatation get developed. And the early treatment, it's better to improve the prognosis. So there is always the risk of the mild to moderate cerebral palsy or cognitive impairment. If you have a grade 4, which is the periventricular hemorrhagic infarction, then the term you need to get the significant risk of the motor developmental problem, usually on the contra side or contralateral side, a cognitive behavior and or visual impairment. It depends on the size and location of the hemorrhage. And usually the parietal lobe involved carry the higher risk of cerebral palsy. So you can see here, I did not give too many details, but I keep it a little bit very clear without numbers. Okay, so it's important when you communicate with the parents, it's very vital and important when you communicate between the healthcare provider and the parents, it's important for keep it simple to make the parents understand the process of the germinal matrix IVH hemorrhage and complication for their lovely baby. And cooperative with the healthcare, with different healthcare provider that's fostering between the facilitate and the fostering collaboration between the parents and healthcare that's enhance the care and outcome among babies. So it's very, very important to build relationship with the parents as early as possible. The early you build relationship with them, it's better. When you time for counseling, it make it so easier between when you start talking to them, because they understand you and you understand them, and then you start building relationship, and that's help and facilitate the bad news or the counseling process. Don't forget that when you counseling the parents, you have to demonstrate empathy. It's very, very important. You need to demonstrate that part. Don't be just machine that you provide information, just you summarize what you learn during your training or during the medical school. It's very, very important to show the empathy, that you feel what they are feeling, and you know how bad it's going to be, or you know how painful for them to have their lovely one that been 4 whole months or of the gestation where she's waiting for lovely one, and then you give them, at the end, you give them that bad news. So it's very important to demonstrate the empathy during the discussion about the IVH, okay? To ensure the parents feel that you are supportive and they are not lonely, okay? Try your best to clearly explanation about neonatal IVH. What does it mean? Okay, and that's help alleviate the confusion, fear during that process, because imagine that's the shock stage is very hard for them to understand it, and that can reduce the parental anxiety, helping them to cope with the stressful situation. There's very important to know that the parents' perspective, hearing is not mean they understand. Initial, when you deliver the news like IVH, whether stage 1 or 2, and more if the stage 3 or even more if stage 4, the parents at the first, they get the shock stage, an intense emotion, and that's required for us to understand this process, because by saying all the information doesn't mean they understand, because at the time their mind sometimes go far away beyond what you are think about it. The entire life, it becomes very, very short in front of their eyes. So it's very important to make it simple as possible, pause, let them process, and make sure they understand what you are telling them. Okay, so it's important to clearly explain the medical finding. The parent may know, even though you explain to them, you think that you did this the best, but doesn't mean that you blame because you tell them everything they should understand. No, sometimes even you did the good job, still that shock stage, the anxiety and the grief make them difficult to process it and understand their child conditions. Important for us to recognize their emotion status of the parents and clear, comprehensive support to help them navigate their experience. How to make the complex process to the simpler? First, try to avoid use medical terminology. Use the simple language, okay? Many parents find that challenges understand the complexity of the medical terminology, that sometimes we understand or that we forgot that we are using the terminology that general population, they are not use it, okay? Try your best to make it simple, clear, use clear language, and break it down to the process, to the smaller, okay? Easy for the parents to absorb it. If you have any visual aid, use it, because sometimes some people do not understand, even because of the language, even because the complexity of the medical conditions. It's better to draw pictures or show them if you have a visual aid. That's make it even better to understand. And again, don't blame if they are not understand, because sometimes we are different words and sometimes our language is a little bit different. So try to speak slow, take your time, and then make sure they understand every important information that you deliver to the parents. As a parent, am I ready for this? That's what they are thinking inside, and they are not evoking, they are not telling you what they are thinking. So it's important during the process of delivering the information, make sure you, in addition to that, show your empathy to provide the hope and support during the whole process, okay? And that's the support is essential and helping to foster resilience and strength. It's essential to give realistic hope. So don't give false hope. So important. You want to give realistic hope while acknowledging the potential challenges that associated with intraventricular hemorrhage, German matrix intraventricular hemorrhage. Avoid giving false assuring, but focus on all range of possibilities. You might offer resources that available, okay, and provide them or reassuring the parents that there is available resources. If they need it, we're happy to provide it for the parents. And sometimes you can connect them later on to the community connection that help parents to communicate each other, and that's help them understand the whole, not only during the acute phase, even during the later on, during the chronic phase, subacute and chronic. The additional resources like online websites, online platform that offer parents easy access to the reliable information and resources. It's important to tell them that to avoid just Google to the general information, like general website like Google, or because sometimes that's what first things as a parent, after you give them the information, they go and Google it, and then they go to the extreme, and not all the cases the same. Sometimes their condition is different than the other, depending on where the lesion. So that's very important to emphasize and tell the parents, if you want any information, come to me, I provide you the information that you need it. So we prepared you as a physician before you go to the giving or deliver the information or counseling for the parents. Number one, you have to do your job. You have to prepare what's to talk about. Number two, you need to involve the multidisciplinary team. It's better, especially if first time, it's better to have the team that support you and support the parents. So the team that you needed, it made from, when we focus of the IVH, you need the primary nurse. As a neonatologist, you are the primary doctor, the nurse that take care of the baby, because sometimes the relationship, the nurse with the mother is very strong, and that's help alleviate the process. And then if you need to involve the neurologist, or baby, if baby have the post-hemorrhagic hydrocephalus and he needs shunt, then it's better to involve the neurosurgeon as well. Make sure before you enter the room and you break the information, make sure that you discuss the whole plan with your MDT, with your partner, or with the group that they're gonna come with you. So better to sit at least 15, 20 minutes prior to the meeting, discuss about what's the information, what's the plan. You don't want to be surprised in front of the meeting, everybody give different image or different opinion that you are surprised you never discuss about it, okay? Or sometimes the parent, they ask question and you don't know. It's better to be prepared, actively prepared, rather than just take the parents to the meeting and deliver the information and then surprise with the questions, or surprise that somebody else give them a different information. So better to all together as a team, you go, you sit, and you have a plan. The parents, they will feel that we all in the same page, and they feel that they are supported and they are not alone, okay? So in addition to this, it's important when you meet with the parents, especially when you have an MDT meeting, the primary physician, he's the one, he should start talking to the parents, and then we will talk about how the process will be. So you designate the point person that communicate the streamline information flow and address the parents' question effectively. And then sharing and making decisions shared between the primary care or the providers and the parents. And it's important to let every subspecialty to give their input. That means they make the parents feel that we are all on the same page, and you are not the only one who has the decision, but that's the sharing decision. So let somebody from the neuro give their input. That's helping the counseling process. So respect the parents' value, preference, while providing guidance based on the best available evidence. When you sit in the meeting, unfortunately, we are not good in this. We should be active listener than just telling information, okay? Especially if we have here fellows and specialists. So it's very important when you sit with the parents, try to be active listening. When the parents talk, don't interrupt, listen. That's give power without knowing. You give them a power. You give the whole meeting that you are powering and you are listening. You feel the parents that you are listening to their concern. And that's very powerful tool. So active listening is a crucial An effective communication as its help, understanding, and response accurate to the parents' input. And then give time. So we said, number one, active listening. Second, try to give time for questions. Allow the time for the parents to absorb and allow time to ask questions during the discussion, and to ensure clarity and help to address any uncertainty. And then constant communication. And as we said, ensure all team members are aligned in their communication, helping to maintain consistency and reducing the misunderstanding. It doesn't sound right if you talk and then somebody else talk, he wasn't in the meeting, and then the parents meet with them separate, and she will give the different information that you give, and then neurosurgeon, he will give another information that's completely different. So that doesn't send a good message, and it happens. A lot of time it happens. So the only way to avoid miscommunication and send different wrong messages is better to sit as the MDT prior to the meeting, discuss with you with the subspecialties, at least listen to them, see what they're going to discuss about, and what's the information they will provide, and what's the plan, short and long term plan, and then you guys go all together. That's give a lot the power during the communication. The importance of trust, building trust with family is essential, as I said. So that's this one only happen if you know the parents from the beginning. So that's why my goal when I start take care of my patient from the first day, I introduce myself and I start building a relationship from the beginning. Because later on, it makes it so easier when you sit with them, because they know that you care from the beginning, you introduce yourself, you've been with them through the whole process. We're going to fight together. We're going to do the best for your baby. We are here for your baby. And then if something happened, then you can sit with them, make sure they understand what's going on. And the parents, they will feel you are the primary. We trust what you are saying. And that's give a lot of the powerful tools to use it for the parents. Keep open communication. Maintain open line of communication that's engage the families to express, again, their concern and seek guidance. And then during the meeting, constantly provide support that help the families feel secure and involve their child care journey. Those is very, very, very important. Active listening, give time for questions, constant among the team communication, empower the trust, open communication during the meeting, and then support with constant support with hope, but not false hope, okay? Realistic hope. Another important that most of us, we forget about it, understand the culture perspective. And that's a huge important, especially we are in the place where we have a diversity of the parents. Sometimes parents from Arab countries, some parents Muslim, some parents from India, some parents from Pakistan, some parents from all over the place. So it's very, and even outside, like when I was in the United States, we exposed to the wide variation of the culture variation. So it's important for us as a provider to respect and recognize this diversity. It's a huge rules. It's very important. Okay, so the parents' understanding and acceptance of the medical information can be significantly influenced by their culture and religion. And sometimes the medical decision, especially if we are talking about IVH in the advanced stages and the decision is making is important, you have to respect their culture and religion belief in that decision. Be sensitive. And I'm going to highlight this one is very important. Be sensitive to the diverse perspective, especially when it comes to their health or the child health. Respect families' religion beliefs. Engage open discussion. If you're not aware, just keep it open discussion. Provider should engage the family to open discussion about how to believe, how their belief impact in the treatment choice and care plan. That's really important because every religion has a different belief and every culture have a different. It doesn't have to be a religion, even culture, diversity. So it's very, very important. Customized care abroad based on their belief and especially if there's on the religious belief. Visual aid and additional resources. We discovered this one already. So it's always use the visual aid. So you have, for example, card. You can explain to them in the simple way make it way easier for the parents to understand the process of the IVH. And that can enhance the comprehension of the parents, reduce anxiety and confusion about the medical situation. Okay, so we discuss about each one separate. So as a provider, how can I know, or how can I make steps or rules for myself, what I need to do one by one step in another? So what we always do, either remind like mnemonic, like spikes, or slowly it may happen when you see your mentor, and your mentor, they doing it on the daily basis, then you're going to learn the way he do it. And then when you read spikes, it make a huge sense what your mentor or what your attending or consulting do. So usually, first you need to know your background, patient. It's very important. Know your patient. Whenever you want to go consult, you have to know at least what's the name, gestational age, some background. You're not going to go just, diagnose and you sit with them and just tell them the diagnosis. It's important to know who the patient. Is it your patient? It has to be your patient. If not your patient and you're covering that day, or you're on call, you have to know at least what's gestational age, some information. It sounds not right if you tell them to sit with the parents, give information, and then they ask you about something and you're not even aware, or you tell them the wrong information. So it's important to prepare before you sit. And then you need to structure the room, and we will discuss about this one, but at least if you have during the night, or better not to give too much information, and then let the primary team handle the counseling, unless it's really decision making. Okay, so you need to have something to help you remember the whole process of the spikes, especially if you are in the OSCE, in the exam, real exam. During the OSCE, we always say you have to have a structured mnemonic to help you during the counseling section. So we'll sit with number 1S, spike. The first one is the setting up the meeting, like what you said. Okay, so first I need to find a place where not too many interruption. I don't want to deliver bad news or sit with the parents about something and in the middle of the unit where everybody walk around. A lot of distraction. Dr. Ayad, I need you. Dr. Ayad, this baby, this, like, it's a lot of distraction. It doesn't make sense. Number one. So number one, set the room. Find a place where quiet, comfortable. Make sure no one interrupt the room unless it's through emergency. Try your best to turn off and that's, we forgot to do it, but it's important to turn off your phone to give at least privacy, and you tell the parents, I'm for you today. At this moment, I'm for you. I'm turning off everything. I'm here for you. That's really, it helps. Okay? Make sure the room have a basic for the counseling, like water, tissue. Make sure that the room is a little bit clean, white, like it's not too dark. Okay? So comfortable environment. Okay? And then involve all the key individuals, as we said, like parents, MDT with the different specialty that you needed, and allocate the time. So if there's not like either you schedule a time for them, which this is the best scenario, you schedule the time, and the parents, they know that they are here for counseling, so they are already mentally prepared. If not, then you have to prepare them that we're going to have a meeting today, if you are available, or in an hour, you guys an hour, or can we go to the room? I would like to discuss with us. Are you guys ready for that? So make sure that they are ready. Assessing the patient perspective. Okay? Make sure before you start, let's assume that you sit like in the room. Second, that's what I do all the time, introduce the people. Sometimes they set too many people around the room and the parents has no clue. They know 2, 3 only. So make sure before you start any further step, you introduce everyone. As a team lead, you need to introduce everyone in the room who is involved in that room. Okay? And then you ask them, so they know that they're meeting. You already asked them, is it the good time for you guys to discuss? We would like to discuss about, so you start prepare them. Is it good time for you guys or no? If you already called them and you prepared them, they are coming for that meeting, make it easier. If they are not prepared, then you should prepare them for this meeting. make the huge difference. So we're gonna have we have a result for the cranial ultrasound, and I would like to discuss with you guys about, are you guys ready? Do you need to call someone with you? If they said, okay, we are ready, you sit, introduce yourself to the team, everyone, or let everyone introduce themselves, and that's even better. And then you start asking the parents. Don't jump to the diagnosis. Don't jump to the, make sure first I need to understand how much the information the parents have about their child. And that's help you a lot so you can build information on top of what they have. Don't just rush with the information, okay? So ask open questions to explore their perspective. Listen actively when they're telling you what they know about. Use your body lecture and listen carefully to them. That's very important tools, as we discussed earlier, okay? So after that, if they don't know that's information, it's sensitive information, then you have to let them know about the information that you would like to share, okay? And then you can ask them how much information they would like to know and respect their preference regarding the information they would like to share. Do you want to be anyone involved with you here? Do you want us to talk about in front of your parents? If there comes with 2 or 3 people, then it's always take permission before you give the information in front of the others. And then now start with the key points is the knowledge. As we said, when giving the knowledge and information to the parents, should be simple, clear, concise language. Okay? Break down, as we said, to the symbol. And then if, for example, myself, I would like to draw a picture, make it so easier, and then give the message to the parents that you understand what you're telling them and you mastered that topic very well. Okay? So we already set the rooms. You're already prepared. You sit with them, introduce yourself and others, MDT with you. If subspecialties with you, including the nurses and the social worker, case manager, whatever who's available, in addition to the neurology or the neurosurgeon. And then invite them slowly and then start with the knowledge. So when we give a knowledge, as I said, build from the last information they give it to you. So if they give you the information and then if it's correct, you're good. You build on that information. If there's some misunderstanding, you need to correct it first, and then you break it down or you bring them why we did ultrasound hit as a routine, or we are concerned a baby becomes sick, drop him, become pale, or become tachycardic, or whatever the reason you order ultrasound. So you bring that information, where start, why we are here, to the point that we did the ultrasound hit, and today we have, or now we get the result, or you look at the result, or you get the result, official result. And that's the huge difference if you are sure. And for example, in those trained in America, and or if you don't know, if you are not trained very well for the ultrasound, if you are not sure, wait, don't tell information until you get the information officially reported. But if you are sure, like the Dr. Aluk, he did a good job by training you guys how to read the ultrasound. If you are sure what you are seeing, then you sit with them and then you break it down. We did the ultrasound today, and unfortunately, there's some blood inside the cavity. That cavity, you break it down the simplest is possible for you. Okay, and as I said, if you bring the visual aid or if you draw a picture, make it even simpler. And then you have to address the patient emotion. As we said, acknowledge their emotion, respond there, and show with empathy and validation, and provide time for process. So that means when you talk to the parents, every time you deliver something, pause and let the parents process what you are saying and make sure they understand what you are saying. And then continue. If you see the mom start have an emotion, she want to cry or she express herself, let her express herself. Take your time. The best counseling when you take off the time from your mind. So don't run over the time. It's not like exam, you have a 10 minutes or you have a time you need to finish. In real life, when you have a counseling sensitive topic, you have to give the time to the parents. You have to turn off your phone and don't think about the time. Sit, listen to them, address their concern. Show your empathy, that's the key, okay? And then after we did preparation, we sit with the MDT meeting, introduce ourselves, and then ask them, what do you know? Is it a good time to talk about your baby today? I'm going to have, unfortunately, not good news about your baby's brain or head ultrasound. We have a result. If they know that they are done, then you build whenever they have it, and then you start break it down in information, pause each time, be active, listen, use your body language. It's key. You have a body language. It's very important tools. You have it, use it, okay? And then at the end, don't just assume they understand everything. And for me, I know a lot of the majority of the literature, they said you have to summarize what's the information. For me, I use different tool. For me, I ask the parents, tell me the whole this meeting, what did you understand? Because sometimes you summarize what you give them and you already, from the beginning, they did not understand, or they understand only 20% of your information, and then you add another 10% by summary. That's not enough. You need to make sure they understand everything you're telling them. So what I do usually at the end, okay, mommy, can you explain to me what did you understand from me during the whole process now? Tell me what's wrong with your baby. And let her explained. And then you at the end, by the end of that meeting, you know 100% that they grasp all information or grasp 50% or 20%. So the summary is the key information, and you target what you want to send that message to them. So you want to tell them that, unfortunately, your baby has bleed. The bleed limited to the certain area or small area. We call it German matrix. With this area, it's the highly vascular area. If they are Arabic, better to speak in their Arabic. If you know their language better. But if you are in the MDT meeting with everyone, use the same language, which is the easiest for everyone, which is easy to understand, which is the English language. Okay, and then you break it down that bleed is limited to the area. There's small, luck is just that area. Still, you need to monitor your baby. You reassure from time to time. So already give this one pause and let them process it. Let them just take a time, and then lucky your baby is, so far your baby is completely well. So far the whole vital sign under control, stable. We have 24/7 monitor the vital sign, and we're gonna monitor the baby's bleed as we go. We're gonna have to do serial ultrasound and etc. So you give information, and then what's the action you're gonna do in order to prevent the progression, or what you're gonna do after that. So you give the information, and then what we do to make sure that they understand that you are on top of your patient. Okay, so that's it's really, really important. So sitting with rooms, with your team, nurses, social worker, or case manager, or BRO in UAE, whenever the other primary nurse, and then the subspecialties. If you have the IVH, we prefer if the neurologist is available. If no, that's fine. At least then consultant with his team. Okay, minimize distraction, sit the room quiet, turn it off the phone, and then let them know that you are here for them. That's number one. And then the perception, what do you want to know so far, or what do you know about your baby? So it's open discussion. Let's at least sense what's going on, what they know about their baby, and then if they are not aware what's the purposes of the meeting, you start invite them to that talk, and then you start explain to them in the simple way. And we learn from, even during the exam, when we examiners through the OSCE, we see a lot of people like that. Some people that they have beautiful way to explain. You feel like that you already, your heart melting. And some people, unfortunately, like the back to back, there is like emotionless. So take this one out. You need to show the empathy. You need to address, and then you have to pause, and then you talk, and then you pause. And then from time to time, you provide the support that they needed. And then at the end, as we said, to summarize it, either you give them summary, but me personally, I would like the opposite strategy, but tell them, okay, now we finish, or after the end, after what I told you, I need to make sure that you understand what I said. Can you please explain to me again? I know it's not easy, but I need to hear from you. What did you understand? What I said exactly. So then she can break it down. If you feel that strongly that she grasped the whole information, then confirm that she's right. If no, then whenever she mentions is misunderstanding from your language or from the way you explained, then you can address it immediately. Okay, so now we just finished the how to break. We've been 45 minutes. Do we still have a time, Dr. Aluk?
Yes, we do. Yeah, we got maybe 10 more minutes and then we'll start some peer reviews. So yeah, 10 more minutes. Yeah.
Okay, so do you want to do the one case, or so at least we can demonstrate it, or you want to leave it on Sunday?
I think I'll take it on Sunday. So we'll start
Okay.
yeah.
Very good. So we can have it a question and answer. If anyone have a questions, if anyone want to share his opinion.
Yes, doctor. Is it
Yes,
okay if I can ask a question, please?
Yes, please go ahead.
Thank you, doctor, for your presentation. I think it was truly beneficial, not only in terms of IVH, but just general talking to parents in the NICU. What I would like to know about is documentation. Sometimes when we speak, because most of these children are in the NICU for 2 months, 3 months, and we speak something today, and maybe 3 weeks down the line, they may not understand or remember what exactly we spoke. So, because I know in my hospital we do like minutes, and sometimes they sign off on it, but again there is a bias, like somebody interprets something in a different way. According to you, what's the best way of documentation during these sessions?
So the best way to number one, when you sit with the parents or we have a meeting, somebody has to assign who's gonna write the documentation, and make sure you document it in the same day, and immediately after the meeting, whenever you have a time, you should write it down, because happens, the longer you leave it without write it down what happened in the conversation, the more you're gonna give either you miss information or you add extra information that's not happened. Try to make it very simple. Don't go in the details, but the most important for the documentation is make sure you write it down, who was in the meeting, the time of the meeting, and who was in the meeting, and then what's the information you provided. The information has to be, and you cover the acute and long term, because what's the main concern later on, the parents, they will say, no one told us, and we are not aware of this, and we are not aware of this. So if you have some sort of format is good. If you don't have it nowadays, there's a lot of technology, you can use it, and there's a lot of format. I'm sure every hospital or every here and there, they have a certain format. I already discussed on this time, I already discussed with the parents about short and long term, including, and you mentioned the complication. And then I make sure, or that already all the questions being answered. Parents ask questions. And if you are particularly about her concern, what you address, we address this and this and this. It's the more you add, as long as don't put yourself like that, just be sharp when you write it down. Make sure your language is clear. And you address the two parts that you discuss with the parents, short and long-term plan. And then all questions of the parents being answered and their sounds understand. At the end, she summarized, and it looks like she understands the whole concept of formation that we are addressed. Because it depends. So if you are counseling for the IVH grade 1 or 2, you better to mention that we discussed, and we let her know that although so far the study does not see the difference, but still under studies, there's some evidence show that they have a risk of mild neurodevelopmental delay. So don't say there's no at all. So let's leave it open, because sometimes she will claim that it's IVH grade 1 or 2, but no one told her. They told her everything is fine. That's grade 1. There's nothing happened. And then later on, her child has some mild neurodevelopmental delay. And she might claim that you did not tell her anything, or she claimed the hospital that her child has a delay and no one told her about it. So I think is my advice is always tell the truth, and a lot of information we don't have it. Like even though is this grade 1, 2 they said, but still studies various. Still there's some window is gray window. So it's better don't say everything is normal. Your baby has only grade 1 is nothing. As you can say it's still there is risk as their child premature, and this premature baby carry a small risk of some neurodevelopmental delay. So it's like that. And I will let Dr. Aluk, maybe he has more in this, if you would like to add, Dr. Aluk.
Thank you, Eamon. I'm really grateful. And yeah, that's absolutely fantastic. So, Shinza, coming back to that question, really, there are a few aspects to it. One of the aspects, obviously, is information and how you absorb it, which, if there's a lot of information given, can be quite difficult. So the parents may not recollect. The second thing is when you talk about situations like this, depending on severity and what you say, news can be devastating. And some parents might have heard but deny it. So they might be in a state of denial. The third aspects, obviously, them certain setups, like especially in India, I know that there's a significant medical legal component of what you're saying, because naturally, when things go wrong and babies develop IVH, doctors get blamed. And really, if it's not heard by the parents, then technically the parents' assumption is that it's not been said. And that's a very difficult situation to be in. Now, there are a few ways around this. One of the ways around this is I would say that every conversation with parents is very much different. It's specific to those parents. And as Eamon has rightly, beautifully alluded to, it's first getting a grip of really what their understanding is of the situation. You'd hope they've had antenatal counseling, which has mentioned this, so that it doesn't come as a big surprise that actually the baby's had some bleeding into a certain area of the brain. But then it's using terminology that you think is simple based on their language that will be easy to recollect. And one of the things that's come up in a big way is the use of pictograms. So, you're drawing it out. But one of the things that I will share with you in the next talk is just the use of small pictograms to give them a feel of really what bleeding is like. And in situations like that, that obviously makes a visual imprint, which is something that stays with parents. Now, for our sake and for the parents' sake, what is also important is what you're saying is understood. So the repeat back that Eamon said will help with recollection later on. And then sometimes you have to reinforce these conversations more than once. And if you have to reinforce the conversations more than once, it might be that if the parents are overwhelmed, you have more than one conversation. But in terms of situations where parents might be in denial and where you might find that there is a kind of you said, but it's not been heard. Your documentation obviously is crucial. So writing, and what I would say is try to write in as lay a language as possible, because that's something that you can give to the parents to read. And really, it's something that I used to do in the UK where our parent notes, they were very much open to the parents to kind of read later on because we realized they might not grasp everything in the conversation. And I used to say to them that, look, I am going to write down what we've discussed today. You're free to read it. It's part of a parent file. And really, if there are any kind of things that you feel you want to follow up on, or you feel that I might have not spoken in as much detail about, we can sit down again. So that's another way for them to recollect. And the advantage of having a parent folder like that on our unit over there is you can have multiple conversations which the parents might want to go back through. So there's a timeline of what's been said. Now, that's much more difficult in our setup here in the UAE, where really a challenge is obviously we use a lot of medical terminology when we write in the notes, and what we might say in lay terms may not necessarily be understood. And for parents to access records, they need to go through a proper governance process, which means that they have to go through basically our human resources team. And we really need to then sit with them and explain things, which is a little bit more difficult. If you're in India, I can tell you for a fact that conversations are recorded in some hospitals now, and really it's for medical legal reasons that sometimes parents may say that it's not been said and it has been said. So those kind of conversations are open for review. I know that in Rainbow Hospital, which is a massive hospital in Hyderabad, they actually record those conversations. But these are just some of the things that I would say, being honest and transparent. And sometimes parents may genuinely not remember. And it's sometimes you may have to kind of start the next conversation by, let me recollect what's been said. And by doing that, again, you're able to kind of bring them back. And they may say, well, I don't remember that being said. And it's acknowledging that
Understand.
sometimes information may be quite overwhelming and what might have been said might not have been heard. So it's that kind of approach. Did you
Dr.
want to
Alok,
come in?
let me
Yeah, Eamon. Yeah, come in.
Yeah,
Yeah,
let me ask you questions
yeah,
because I start doing this and I find it very helpful. Use the technology.
yeah,
Um, it's help you a lot, especially now we have a AI. So I think is the AI, especially for the documentation, because her question, I think, if I understood it correctly, she wants something the documentation.
yeah,
So when you like whenever the AI you used, you can write what happened during the conversation, and beautifully they can rewrite it in the way, uh, and then you can revise it, and then you can copy it, and then you can put it on the file. Make sure you read it very carefully because you don't want to put something that's wrong. So AI make it sounds really nice and sharp and medical legal correct. So sometimes our language is a little bit uh, it's not an appropriate because some they have a little bit different language from one to another. So with the advanced technology nowadays, I think we should use it, but you have to be carefully how to use it. And I start using it, and it's very, very, very powerful tool. Read it, and then I like the idea that just you have to be careful when you give it to the parents or you want to handle the typing. You don't want to excuse them that, okay, here what's the written, read it. I want to make sure that but I like the Dr. Aluk, what he said is really good, that if you're interested to read, we will give it to you, our conversation or something like this. At least you are not like the defending yourself that, okay, I need you to write what I read what I wrote. So at least you say, okay, everything is going to be written in the file, and I'm happy to share with you what we wrote, at least for future, if you have any questions or for the future reference. So, and leave it open for them to discuss. But what from my experience, and I think Dr. Alok, he agree with me, I think knowing the patient very well before the moment of conversation make a huge difference. If they trust you from the beginning and they know you care about their child, at the end when it's something happen, they will be with you because they trust you, they see what you are doing, they see that you are doing the best for your child, and then you support each time what you do to explain to them. That's make a huge difference when you sit with them during the counseling. Does it make sense? Any
Yes,
other questions?
thank you so much.
Any other questions, folks?
Can I ask a question, please?
Go for it.
Yeah, thank you, Dr. Ayman, for the talk. I am just in the process of drafting cranial ultrasound guideline for our unit, and I was wondering if there is an article or a study that you can share with us which clearly talks about the prognosis.
Yes, actually, I will share with you. I will share it in the group, or I will send it to Dr. Sharma. There's a beautiful book recently published, and in there's PDF form. I can share with you about the way you counseling the parents, prognosis, everything what you need from A to Z, and I will share with you. Yes.
Thank you.
No,
And
thank you for the question. I forgot
yeah,
to do that.
just to add that the next few sessions, like we've got 3 more sessions, which will purely cover this prognosis. But in particular, the important thing about it is, us talking about prognosis as Eamon has done today, it's challenging for us to kind of talk about it in numbers sometimes with parents. There's certain phraseologies, certain kind of terminology that you have to use depending on the parent, their affect, how they've understood things, their culture, as Eamon's rightly said. And we're going to practice that. And the beauty of it is we're a multidisciplinary group with people who come from different cultures. So on Sunday, we're going to spend some time where we will give you cases in groups of two, give you time to kind of discuss them. And really, what I will be doing is tomorrow evening, I'll circulate the 4 cases that we're going to discuss within the group so that you can have a look at them. There'll be a short history with images. And the intention from our perspective is you can have a look at them and have a think about what you're going to say. But then and I will talk about an approach that I take to prognosis, because there are parents, they may be very educated parents who are really keen to know numbers. I've been in a real fix with some parents where, not only did they want numbers, they had read much more than I had read of recent times. And when parents are very educated, it can make that situation quite awkward because they want a lot more than parents who might really just want to understand the difference between disability and impairment. And really, for some parents, it might be enough for them to know that actually my child has a big bleed in the brain. But the question I'm asking you is, will he go to normal school? Will he be able to walk? Will he be able to play soccer? And that's a very different conversation to parents who really want to kind of have an understanding, is he going to get his A levels in maths? And we're not going to have crystal answers for either of them. But then knowing some elements of the literature and how you address that situation becomes quite important, and we'll have a lot of it.
Yes.
One
And
time for
again,
one last question. Yep. Okay. Eamon, anything to say? Beautiful
no,
talk
that's,
today.
I think, yeah, I think is thank you for having me again. Again, knowing your patient very well, knowing your
Yep.
parents, start building relationship with the parents, and then remember Spike, make it the process easier, and then be systematic, use it on the daily base. Then you're not gonna remember Spike anymore. It's gonna be part of your daily life. Because when I practice in United States, for me, at least at the beginning, I never heard about Spike. So, but I see during my training, everybody what they do and start build this kind of like the same rhythms. I introduce yourself, everybody introduce, start learning from them the open question, and then give the time for the parents to express themselves. Show like the whole process, and then summary. And I learned this one, and then when I start to read during my fellowship and residency, when I start to read about it, I discovered Spike. I said, "Wow, okay." And I'm been doing it for at least a month, and then I realized that is already correct. So my point is try to practice from tomorrow when you go to whenever you have it, try to do it in the right way. Like when you drive the right way, it become part of daily life. If you drive wrong, and then only when you see the police or you see traffic like the signal, you slow down, that's you always going to be they catch you, and you're going to do mistakes. So try to do it in the right way, make it part of your life. You will see a huge difference is going to change even your personality.
Thank you so much, Eamon. God bless you. What we're going to do
Thank you.
now is, guys, we're going to do a little bit of peer review. Uh, so, are
If you
you
don't
able?
mind,
Yeah,
I can drop off.
yeah. Please, please,
Thank you
completely.
so much.
Yeah. Thank you so much,
Thank
Eamon.
you. Thank you, guys.
So Anna, do you want to share?
Yes, Alok.
Guys, for prognosis, the next slide show that I share with you, the next session, I will be giving you bite-size kind of approaches to how we prognosticate. Very simple approach, which basically divides IVH into groups of kind of babies less than 26 weeks and then 26 to 32 weeks. And then really talking about the term baby who doesn't have IVH and the risk of disability there and how. So that entire approach will on Sunday will be summarized with embedded files in the references. The textbook that Eamon's going to share with you. So there's a whole chapter of prognosis in your Dropbox, which you can have a look at. But really, the PowerPoint will have those references. So please don't worry too much. Go for it, Anna.
Okay, Alok. I'll share a case of a term baby that was born in a poor condition. He needed PPV and oxygen to recover with a PCAR score of 378. And I did the ultrasound on the third day of life because he had developed the early onset sepsis with hypotonia, difficult feeding, and the CRP raised up to 20. The CSCF was normal, but we only have the results later. And at this time, we were waiting for the cultures. We started on antibiotics, and I did the ultrasound scan. I started from the first scan on the coronal plane, and we can see the interhemispheric fissure, the orbits, and everything seems okay in this scan, I think.
Yep, yep.
And going further back, we start to see the corpus callosum here,
Yep.
and the lateral ventricles,
Yep.
and the sylvian fissure.
Perfect.
Okay. And here we have we can see more the ventricles and the third ventricle, and the corpus callosum also, and the sylvian fissures. And we are starting to see the temporal lobes.
Mm.
And here, yeah, I was referring that here we can start seeing these linear
Yep.
echogenicities on
Yep.
both sides.
Yep.
And we have to confirm in other plane, but
Yep.
we can go see that further.
Yep. Mm.
The dancing lady, we call it the Christmas tree here
Yep. Yep.
in our
Christmas tree.
unit.
Yep.
Yeah. And I think we can see some spots also here,
Yes.
some
Absolutely, no doubt.
densities.
Yep.
And here, some
Yep.
densities, yeah.
Yep. No doubt about it. Absolutely.
Then we have the plane with the choroid plexus. It looks okay. And the last plane on the coronal planes with the interhemispheric fissure, the parietal and occipital lobes. So going to sagittal, we have the midline. We can see that the corpus callosum seems okay.
Yep.
The cerebellum, the fourth ventricle, and the cisterna magna. And here I think it's fine. And then going lateral, we confirm what we saw in the coronal planes with this hyperechogenous linear, the vasculopathy.
Yep. Absolutely, no doubt about it. Yep.
And with Doppler, we can check that these are vessels
Yep.
that are calcified.
Yep.
On the right side, and also on the left side
Yeah.
also.
Mm.
I don't know if I can put the video. No, it's just to see the vessels.
Doppler. Yeah.
Yeah. Yeah.
Yep.
Okay. And the left side more lateral with the sylvian fissure.
Yep.
The Doppler was okay with the resistive index with normal value.
Brilliant.
And I tried to check the posterior fontanelle, although it was small, but I think we can see here
Yeah.
that we have that spots.
Yep.
That
They're also visible over
white
here.
spots, and on the left is more evident the vasculopathy.
Yep.
And
Correct.
then I did the mastoid view, but only can check the cerebellum on perpendicular and the axial planes. So we had lenticular-striate vasculopathy in the term baby with sepsis. I think it's not usual. So we required the CMV in urine, and it came negative. Now I know the result.
Sure. Sure.
So the baby is going to be followed up.
Yeah.
He recovered from the sepsis and had discharged home, and he'll come back to do another ultrasound scan later.
Yep. So beautiful images. I mean, beautiful images. They're absolutely amazing. And you've got all the anatomy. You've been able to demonstrate everything perfectly. So well done. God bless you. Do you have another
Thank you, Alok.
case?
No, it was only that images that I
That's
saw
fine.
you before.
Okay.
Okay.
Alberto, are you able to share today?
Yes.
God bless you.
Okay, just a
May I
second.
ask one question?
Yes, please.
For يعني the previous ultrasound image on C6, the brain looked like there is spot everywhere, or it is artifact.
That's the occipital region, right? Yeah. So that my gut feeling is artifact. It's not spots, and some of that might reflect. If the baby has hair as you're going towards the posterior fossa, sometimes what you get is you get artifact. So that wasn't significant spots. I know what you're saying. Yeah. It's nothing that I would be worried about. Go
Can I
for it,
share?
Alberto. Yeah, go for it,
Okay,
Alberto.
I was waiting. Okay, so are you seeing?
Perfect. Audible and
Okay,
visible.
changing the monitors. This case is a preterm baby of 35 weeks and 4 days with hypoxemic encephalopathy. Just a second. Okay. The mother has hypertension during pregnancy. The CTG was very bad, and the obstetrician decided urgent C-section. The baby needed resuscitation and was ventilation, and I had ventilation, and the blood gases were very bad with severe acidosis. He was ventilated, had a Thompson score of 13, and was accepted in a level 3 hospital for hypothermia. At the level hospital, he had seizures, so they did phenobarbital and left Tiraceta. The cranial ultrasound was abnormal, and with 5 days, they made a MRI who shows lots of lesions and a big hemorrhage at the level occipital horn of the left lateral ventricle. He returned to our unit with 7 days of life, with left Tiraceta, hemodynamically normal, breathing spontaneously without oxygen support, but the baby was very hypotonic, was unable to feed, and have very slow reflexes.
Mm.
I made this ultrasound with 20 days of life. So 38 weeks and 3 days corrected. We are seeing C1, so the orbit, the interhemispheric fissure, the frontal lobes. I think the blush is normal.
Yep, perfect. Beautiful image.
C2, I see the lateral ventricle, the corpus callosum, the interhemispheric fissure. C3, I see here the foramen of Monroe, the thalami. I don't see anything abnormal.
Yep, agree.
And here, C4. C4, I have some doubts.
Hmm.
I have the dancing lady, so here the correct plexus, lateral ventricle, thalami, but the dress of the dancing lady looks abnormal to me. I was expecting a more homogeneous image.
Yep,
It looks a bit hypoechogenic here.
yep. Especially in front of the cisterna magna, that area in the middle, which is basically the vermis
Yes,
of the
yes.
cerebellum. Yeah,
It's
it
very
does look.
strange.
Yeah,
On the C5, so at the trigon level, I see this image. I think is a cystic image post hemorrhagic lesion referred on MRI.
Yep.
I show Okay, and here on C5-2, I see better the cystic lesion, and I measure it 1.2 centimeters, and I don't see anything more.
Yep. So possible porencephalic cyst in evolution. Yeah. Yep. Well done.
C6, I think
Yep.
it's normal. I see occipital lobes with, I think, normal blush.
Yep.
And sagittal midline, so S3.
Brilliant.
For ventricle, and the same area I didn't like here, a bit hypoechogenic. I was expecting vermis, so I think it's the more hyperechogenic part of the cerebellum, but
Yep.
here is not hyperechogenic.
No, you're right.
Here, I think there are some artifacts. Is in here.
Yeah.
On S2, so parasagittal right, I have a blush, but less than the correct plexus. I don't think it's important. I think it's not pathologic.
I agree. What gestation is your baby?
38 weeks and 3
38
days at
weeks.
this time.
Okay.
Then S1, so lateral parasagittal right, with the Severian fissure, the insula, parietal area, temporal. I think we have dropout here. So I think here is the frontal and occipital lobe theory, I think, but we don't see because we have dropouts.
Yep.
Yeah. Okay. S4, parasagittal left, we see the cystic lesion here with some residue on it. And I don't like this image. I read that the thalamus and the caudate should be isoechoic, but here is more
It's brighter. Yeah.
hyperechogenic than
Yeah. Yeah.
the thalamus area. So,
Yep.
okay.
Especially the caudate area, definitely. You've got a
Yes.
brighter blush there. Yeah. Yep.
Here, the measurement of the cystic lesion
Yep.
in the lateral ventricle, occipital horn of left lateral ventricle. So 1.5 centimeters and about 9 millimeters.
Yep.
The
Which,
same area, sorry.
yeah,
You are,
it's a beautiful image. And for those of you who are looking at this image, it's so important. So 38 weeks, I mean, the ventricle should be very much slit-like. So especially this ventricle, both in the sagittal and the coronal views looks quite prominent. And really, this is an area of porencephaly within the parenchyma that has merged with the ventricle, as you can see over here so beautifully in the MRI. So, you'd hope the baby, prognostically, if he's doing well, is he feeding orally?
3 days after this ecography, it was discharged, completely different. Tonus practically normal and feeding completely normally.
Yeah, brilliant.
We were all surprised, not expecting the evolution. I put this image of the MRI with 5 days because I think this was the hemorrhage with on T1, visible on T1, and this cystic is the evolution, I think, of this hemorrhage.
Yeah. Very focal, very localized, and a huge opportunity here for the child in terms of neuronal plasticity to make a recovery. Opposite side of the brain, hopefully not affected. Were the seizures really bad? Were they very difficult? Did you have multiple kind of? Did you have?
Multiple episodes, but I don't know. It was not in our hospital.
Sure,
It was in a
sure.
level 3 hospital. I only have the registered information, but a few times, but I'm not sure. I have not all the information.
Brilliant
But
images.
no seizures in our hospital, always well.
Yes.
Neurologically, it was very hypotonic, but improving, and when discharged, almost normal. If we didn't
Amazing.
know it was normal.
Lovely.
now T2 image with 5 days to compare. We'll see here the lesion, the hemorrhage lesion very well. And the report of the MRI with talking about this lesion.
Hmm.
And I pass.
Focal enlargement of the ventricular system, yep, and reactive dilatation of the temporal horn.
But more lesions. I have the registry of the MRI. There are more. This lesion was the more important, but the baby had lesions, cerebral lesions, thalamic lesions. Now S5, Sylvian Fisher, Insula, resistant index normal, 0.84.
Yep.
And the evolution, very good improvement, and everybody was surprised. In 2-3 days, the baby changed completely, looking like a normal baby when he was discharged. Is doubts that I have. What periodicity do you suggest for cranial ultrasound? And when do we have to repeat MRI, in your opinion?
So what I'd say is that the initial cranial ultrasound that would have been done, in therapeutic hypothermia, with usually a follow-up at 7 days, and then really what we try to do is we tend to do early MRIs, preferably as close to day 5, 4, 5 as possible, because you can do diffusion weighted imaging and SWI, which basically gives you an idea. Also, MR spectroscopy, which basically gives you an idea of the lactate within the brain, which can tell you when and how the hypoxia ischemia might have occurred. Now, in terms of repeat MRIs, the real question that we ask ourselves is it something that's going to alter our prognosis if we are going to find something? Because we're already going to follow these babies up neurodevelopmentally. And the prognostic kind of correlation of the posterior limb of the internal capsule tends to be most specific. Like if you have abnormalities, then the risk of an abnormal neuromotor outcome is about 80%. But when you look at lesions in the thalamus and the basal ganglia, along with neuronal plasticity, the correlation with an abnormal neurological outcome in isolation, the sensitivity and specificity much lower. So actually, in these situations, the majority of institutions that I've worked in, if the baby is normal neurologically and continues to follow up, then we would not repeat an MRI. The only indication for doing an MRI is if the baby develops other abnormal neurology. And a classical example that I'll give you is a baby who suddenly develops choreoathetoid kind of movements, a baby who might have persistent seizures on anti-epileptic treatment. Those are kind of situations where you might worry that the brain is having further insult, or that a child might have something else underlying that might be developing. So in isolation, after the first MRI, we rarely repeat MRIs unless there is persisting focal neurological deficit. In terms of cranial ultrasound, it's a really interesting question. I think for the severe cases, it's very interesting. If they're still with you, then doing an ultrasound at 14 days can tell you a lot. I've recently had a baby where we scanned who had grade 3 HIE. And I mean, we basically saw massive degeneration of the brain with significant, I would say, cortical leukomalacia, subcortical kind of damage to the baby. And I mean, the MRI itself was catastrophic, but when you look at the cranial ultrasound, it was pretty bad. Now, again, the question that people will ask you is that cranial ultrasound wouldn't really alter much because we'd already decided on palliative care based on the resuscitation clinical course, clinical history, and the MRI changes, as well as the amplitude EEG. But we'll talk a little bit more in detail about this when we talk about prognosis. Very nice images. Nothing for me to say in terms of, I think, beautiful.
Thank you.
God bless you. We have Dr. Amani. Dr. Amani, would you like to share?
Yes, yeah.
I mean, you can see how as the course progresses, I mean, there's very little input that I need because the images are as good as an expert would do them. That's what I'd like to say to both of my colleagues who presented today. Beautiful images. So
Thank you.
Okay, good evening, everyone. So I'm sharing a case of a mother who's 34-year-old lady. Parents are not related. She's a healthy lady who previously had an ectopic pregnancy. During this pregnancy, she had a normal serology, but antenatal scan showed multiple congenital anomalies. The head circumference was less than the third centile, subtated lateral ventricles, large abdominal cyst anterior to the liver, dilated loops of large bowel, and middle two fingers of left hand were fixed in flexion. The family declined amniocentesis and requested for resuscitation. So baby was born non-vigorous and needed to be intubated. The birth weight was 1.2 kilogram. This baby was a 27-week, or sorry, I didn't write that. On examination, there was microcephaly, syndactyly of the left hand, distended abdomen, and a heart murmur. So as part of our investigations, I will start with the cranial scan. So this image was done in day 2. So, sorry, the baby was very sick and was oscillated, and there I had to go between many machines to get to
yeah,
the baby.
no problems.
So, yeah, so we can see that the orbit, the interhemispheric fissure, it's not central, but the best I could get.
No, that's very good. Well done. For an oscillated baby who's so sick, it's never going to be easy. So well done.
And this, you can see the lateral ventricles. You can still see some of the corpus callosum. And
Yep.
then I wasn't sure what to make of this part here. A
So,
bit echogenic.
yep, especially on
And
that. So just my only other comment is labeling. So I'm assuming the marker is on the right?
yes, yeah.
Lovely. Perfect. Okay. Yeah.
Yeah. And then there's this echogenic area here, which
Yeah. That
again,
is.
yeah.
So can I just say
And
it's a beautiful image for the
thank you.
machine that you have in such a sick baby who's oscillated, never easy. But
Yeah,
immediately what stands out is that if you look at the temporal lobes near the uncus,
yeah.
it looks very bright, and the paraventricular area. So I'm just going to highlight it so my other colleagues can have a look. So this area
Mm,
here, the paraventricular area. I mean,
mm,
this, considering the gain settings, this is
mm,
really bright. Uh,
yeah,
the question obviously is you've got choroids over here. Right choroid looks a little bit more bulky. It'll be very
mm,
interesting. And just the cerebellum looks very bright as well. So
yeah,
yeah,
yeah.
it is normally bright, but it would be interesting to kind of see how your scan progresses. Go for it. Yeah.
Right. And again, the extra axial space, I'm not sure if that's normal. It just
For a
the
27 weeker with the scanner you're using, absolutely. Looks fine. Yeah.
right. So that's the next one. Still, you can see there's this echogenicity.
Yep.
The cerebellum very bright and these bright areas
Yep.
here. Um,
So in terms of
right.
resuscitation, can I just ask, did your baby have compressions and adrenaline?
No, we didn't. No, we intubated immediately based on the size of the abdomen and the fact the baby did not have any respiratory effort and did not respond to initial PPV.
Sure. Okay.
Yeah. So here are the choroids, a little bit bulky on this side.
Yep.
Um,
And very dense flare. So
yeah,
very, very dense flare. If we just go back to
yeah,
that previous image,
sure.
brilliant image again. Very dense flare. I mean, it's flare that almost at some point becomes as bright as the choroid. Uh,
Yeah.
it's definitely something that I would be following up very closely considering the previous image. Can we go back to your last image, Dr. Mani?
Sure. This one?
No, the
The
one
one pre
yeah, yeah.
before, yeah.
I mean, my only comment here is it's just like you're getting what we call as the quad sign in this region, ipsilateral, which would strongly be correlating with possibility of hypoxia ischemia, especially
Mm.
kind of middle cerebral artery. So, and then when you go to the next image, you have significant flare again. So,
Yeah.
yep, carry on. Yep,
Yeah. And then that's the occipital. You can still see the interhemispheric fissure.
yep,
Okay, and that's the midline. It was
yep,
difficult with the proper one. You can see the cerebellum. You
yep.
can barely see the corpus callosum.
I can see
Uh,
it. I
yeah,
can't see it all the way anteriorly, but I can see
uh,
it. So well done.
right. And then there's the fourth ventricle.
Yep.
I was also wondering about this part because I know that antenatally they were saying about lateral ventricular septation. But to me, you'll see in the other images, would you consider this septation
No,
or?
no, this is more when you look at your images, and I'll just, when you look at
Mm,
your probe is a curvilinear probe,
yeah,
and what you're probably getting over here is basically an element of dropout.
okay.
Uh, I think with elements of artifact based on how the ultrasound waves are coming back. Your probe is like normally what we'd like is ideally the probe being completely in the center. So if I just draw it out over here like this, and I just think your probe is probably a little bit angulated, which means that
Mm,
you're seeing more of the anterior part and less of the posterior part because of the dropout.
sure.
So the lateral ventricular septation will usually be seen in the coronal and sagittal views. So,
Mm,
but let's carry
yeah,
on. Yep,
yeah, I have a linear probe image, yeah.
yep,
And then that's the right
yep.
ventricle, the sagittal view. Again, a bit of a flare, and I
Yep.
wasn't sure about this
This
part.
is posterior horn of
Yeah.
the ventricle. It's not a cyst. It's
Mm,
just the cut you're getting. The posterior horn basically looks like a cyst. It's not. So
mm,
in an ideal, your C would be like this.
sure.
So just
And
with the
yeah.
way the angle is coming. Now this area, so just be aware, this is the brain.
Mm,
Okay. This is the kind of occipital lobe. This
mm,
is actually outside. Now,
right.
the question that I'd be asking you is, was there edema of the scalp? I mean,
Yes, I mean, it's for a 27-weeker who was 1.2 kilos, we
yeah,
felt that there's an element of high drops. Yeah.
yeah. And I suspect this is soft tissue. Uh,
Mm, okay.
and I mean, just my only other thought at this particular point is whether you've might have some blood there, but again, that would be clinical correlation, but that's
Mm,
outside the brain. So that's not
okay.
inside. Yep.
Okay. And that's the right. I tried because I was concentrating on that part. I
Yeah,
felt that was a bit, yeah. That's why I tried to get that part of the brain. So again, a bit of a flare. Nothing I can see, maybe a small bleed in the ventricle, but nothing that's obvious.
sure.
Would you consider that a
Uh,
bleed or?
It's possible. It's possibly a
Mm,
subependymal, or it could just be bulky choroid. An intrachoroidal bleed can't be completely excluded in this situation. I'd be very curious. I mean, how old is the baby at this age?
2 days old.
2 days old. Uh, would you be able to scan this baby again?
Unfortunately, the baby passed away.
Oh, I'm so sorry. Yeah.
Yeah.
I
Yeah.
just, my only worry here is with the soft tissue and the swelling is whether
Mm,
you might have bleeding, like very much a subgaleal kind of a bleed. It's just,
sure.
it's very odd. I'm pretty sure this is outside the level. Did he drop his hemoglobin?
Not much,
Not
no.
much. Okay, no
Yeah.
problems. I'm so sorry to
Okay.
hear about the baby. Yeah,
And that's again the right sagittal.
yeah,
And again, more of the right
yeah,
sagittal.
yeah,
The left.
yeah.
So,
You're getting an artifact which you commonly see.
mm,
This is quite interesting.
mm,
Wonder why you're getting dropout over here. This is quite interesting. Hmm.
mm. And I'm getting it in many scans, actually, many
Yeah. Are you getting
types.
this in a lot of other scans as well?
No, only when I scan this baby, that's what I'm getting most of the time.
It's very, very interesting. Okay.
And then I used the linear probe
Yeah.
to try to get more information. Again, ventricle seam find whether
Yeah.
this is the beginning of the choroid or a small bleed, a bit of
Brilliant.
a flare, yeah.
Yeah.
Sylvian fissure,
And again, you're getting the quad sign. Can you see how bright those areas look?
yeah,
Ipsilateral. This
yeah.
this area, very
Mhm,
bright. And then you have
mhm,
significant flare. I mean, I'd really be worried about hypoxia ischemia in this kid.
mhm,
Cerebellum, again, the vermis always looks bright.
yeah,
Generally looks bright. I think the cerebellum is probably okay in this, but definitely you've got the quad sign. Yeah, carry on. Yeah, very nice image. Beautiful.
and that's
Yeah,
another
and
one.
I feel more likely you have intrachoroidal hemorrhages, most probably
Mhm,
because the choroid's very bulky in this.
mm,
Yep, yep,
that's another one.
yep.
Yeah, so
Beautiful. Brilliant
mhm,
image. Yeah. And I mean, just folks, just you can see using a linear image how important that is. Now, this is the bit that I'm a little bit concerned about. You can see the cortex.
mhm,
So this is basically the meningeal layer, and it's this area over here where you have a little bit of dropout. Now, the
yeah,
question is, are you getting a little bit of artifact there because of dropout, or do we have an element of a bleed there? Because subdurals would be the other thing, but they tend to present with a wide interhemispheric fissure, which we don't have over here.
no, yeah,
I think, this would be a very interesting scan for us to discuss with a pediatric radiologist. I think
mm,
there's an element of artifact coming in there, but uh, with your permission, are you
sure.
happy if I anonymously show this to one of my pediatric radiologists?
Yes, of course, yes, please
That's
do,
very
yeah.
kind. Yeah,
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 yeah.
yeah,
Okay, yeah, that's the occipital, and then that's the midline.
yeah.
And as I said, I was fixated on this part, which just looked, yes,
It's bright.
yeah.
This is definitely outside the brain.
Mm,
This is
mm,
soft tissue, and often you'll get this kind of an appearance. And the important thing is the harder you press, if there's edema, you will
yeah,
often get these zones of dropout like this.
yeah, okay.
The interesting thing is the bit that
Yeah,
I'm really concerned about is we're very hypodense. So if you look at this region here, now the
mm,
question is this dropout because of artifact or is there something going on? This is outside the brain.
okay,
This is soft tissue. Yeah,
okay.
yeah,
And then again, I mean, this is it seems like a dropout,
yeah, yeah,
but
yeah.
yeah. Okay. Um, is this anything significant?
It's a little bit tricky to say with the gain settings as they are, but
Mm,
definitely a very bulky choroid. And
mm,
can I ask, this is the midline, right? It's the right side.
right side.
Yeah, it's the right side, and it's a sagittal image. Okay, carry on. Yeah,
So that's
yeah,
the far right.
yeah.
So
I
the
have a
left.
feeling that you're having dropout anteriorly. Just
Mm,
the one thing to be very cautious, you're not seeing this in other images on other babies, right?
no, no, I don't recall. No.
Okay, that's fine. So sometimes in situations like this, the best thing to do is to speak to one of the pediatric radiologists just to kind of find out whether there's an
Okay.
element of dropout over here because of
Mm,
the way the fontanelle is. But the thing about dropout is you should not get it on the linear probe. I
mm,
can understand it coming in the convex probe because these areas will be difficult to see. But the fact that you're seeing it on the linear probe, the question is there something else going on there in the frontal lobe?
mm.
So, yep, something for us to ask. Yeah, and
That's
that's very
the left.
right.
Yeah.
And again, just that is the bit that worries you. So I'm not worried about this. This is outside the brain. But the
Okay.
question is very hyperdense over here, very
Mm,
hyperdense over here. So just again, the question from our perspective is my worry is whether this baby's had hypoxia ischemia. And
mm.
yeah,
And that's
yeah,
again, this is our image of the left.
yeah,
Okay. So just to update you on the baby, we did abdominal scan, which showed a large multifocal cystic lesion in the upper part. And it's more originating from the left liver lobe. They queried whether it's a hamartoma and left multicystic kidney. The baby had severe biventricular dysfunction and evidence of PPHN, so ended up in
I
INO.
I think I've got my answer. You've
Mm,
deformed cranial bones. So that's why you're getting those kind of pictures.
sure. Okay.
Most probably because of the deformation of the cranial bones, you're getting
Mm,
elements of dropout, and what you'll find is we call it artifact, secondary to the way the ultrasound waves kind of interact with the cranial bones. That's why you're getting that appearance. Yeah.
Torch screen was normal. The
Mm.
genetic and metabolic studies still pending. Baby was ventilated, required INTRO, but had persistent metabolic acidosis, went into renal failure, and expired on day 3.
Yeah.
So yeah, that's as far as we got to. I mean, baby expired 2 days ago.
So sorry.
Yeah.
Very good use of both probes to get your information. And again, a really good example to the group that sometimes you might find it. This is a very challenging scan. The reason the scan is very challenging is because you have deformed skull bones. And a very good example is if you have a baby with Epert's or Cruzans who've got a very small fontanelle, as I suspect might have been the case with your baby, a 27-weeker anyway. I mean, you've done very well. I think the linear images that you've got, they're absolutely amazing. So my compliments. Well done.
Thank you.
Amani, I have now seen, this is your third scan.
Yes.
Remind me, you saving to the Dropbox at the moment?
I am not. I have several images that I need to share in the Dropbox.
Yeah.
I need to go to the initial video that you have sent us to know how to do it,
So
because I
what
mean
I'll
I
do
have
is,
about 8
yeah,
scans. Yeah.
I'll send you the link again.
Okay.
All you have to do is click on the link and you will get a common folder for you. If you save these PowerPoints in one folder and
Yeah.
put them into the Dropbox, I will organize them.
Okay. All right.
Okay,
Thank you
so
very
I
much.
will do that tomorrow morning.
Okay. Thank you very much.
No problems. Very nice images. Uh, I think that's the last one. Does anybody else have any want to share? Nashwa's going to share next time. I think that's it really. Guys, can I just say that the next 2 sessions will not be recorded and they are very interactive and they're the best sessions. And really, the entire concept is that we give you in a nutshell an approach to prognostication based on your scans, really how to have the conversations based on culture, and it will be role play. So it's going to be an hour and a half of interactive kind of workshops with an approach. The PowerPoints are all going to be shared with you. So all the PowerPoints we have so far, I've put in one Dropbox folder and I will share the link with it with you. But on Friday, late tomorrow evening or Saturday morning, I'll be sharing 3 cases with you. And basically, the intention is we'll be talking about those 3 cases, and they'll represent a history with different grades of IVH, scans with the clinical course. And the intention from our perspective is we'll be having conversations with and role playing with actors, myself, and Dr. Ranjit. And really, there's nothing to lose by saying what you're going to say. And then after that, really, the way we're going to work around it is we're going to discuss the literature around each of those scans to give you an approach. At the end of it, we leave you with a simple approach to how to approach grade 1 to 2, grade 3 and 4. And really, the important thing about it is not every parent wants to know what the percentage chances are. And really, the risk of neurodevelopmental impairment, uh, parents really want to kind of know what their children are going to do. And we don't know how to do that. We don't know what to say because we don't have a crystal ball. But really, there are words, there's a way to put it to kind of, the most important aspect is to give them hope, because really what they do after the baby goes home is much more powerful in molding that baby's neurodevelopmental outcome than all the intensive care that you'll give this baby while he's with you in the hospital. And, one of the cases that I'll share with you is quite a remarkable example of that. So thank you all for your patience. God bless you all, and I look forward to seeing you on Sunday. Have a good day, everyone.
You too,
Thank
Alok.
you.
Thank you.